Right, right. And I think newly diagnosed is understood, but Dr. Kishore, what does it mean when, somebody refers to as relapsed or refractory or recurrent?
Dr. Nataraj has very beautifully pointed out the different treatment options which are available. Generally, when the patient is presenting to us for the first time, and the uniqueness about this leukemia is the only way we diagnose, which has been already discussed in the previous webinar, is through some blood test. And unlike other cancers, which can come up with some swellings here and there, where the patient notices himself or herself first, leukemia, sometimes it just goes to the general physician because of some vague symptoms, and then it gets picked up through the different signs and symptoms and diagnostics. So once the diagnosis is done, this is a blood related cancer, blood cancer for that matter. So it is there everywhere in the body. So Dr. Nataraj has very clearly pointed out the 4 stages of treatment, where if you see at every stage, the treatment works at a systemic level. When I call systemic, it is not like I'm going to go and do a surgery. Whatever the type of treatment I'm going to give is going to go to the entire body and work in each and every place where the cancer has been. So we don't call it a staging here in leukemias, but we kind of try to stage it with the different other modalities. But the baseline treatment, as over the years, what we have learned through different protocols, which Dr. Nataraj also very clearly mentioned, even we have our own localized Indian protocols also shooting to the needs of our local children as well as the local situations around. And we do derive a lot of protocols from our Western colleagues. So all these protocols have got a specific set of chemotherapeutic agents which go target and try to kill these cancer cells to the deepest level as possible. But when we kind of do the therapy, it is not like a 1 week or 1 day therapy. Most of these protocols will have therapies which are running for maybe a few months, more intense, and then over a period of time, a concept called as metronomic chemotherapy or maintenance is something which is quite common in acute leukemias, especially lymphoblastic leukemia. So it's a very stretched out therapy. So during the therapy, we just want to make sure in the intensive phases, we keep on doing checks. Sometimes we do bone marrows again, just to check the disease has not come back. We have achieved what we actually wanted to achieve, because these are cells. We are talking about cells which are like very minuscule, going to only a few nanometers. So naturally, right, it's not something which I can grossly see and say that it has come down. So it needs very specialized testing, sometimes genetic testing. We do bone marrows, we do high sensitivity flow cytometries, where we look up even 1 in a lakh or 1 in a million cells to say the leukemia is gone. But in spite of all these things, sometimes the genetic mutations are whatever the thing that is causing the leukemias are so aggressive that it is possible that some cells may be inherently developing a bit of a resistance to the initial set of drugs what is being given, and it is possible that they may start to come back again. Even the patient may be on therapy, or sometimes he or she would have completed therapy. It's not the case everywhere. 70 to 80% of times patients do carry on with their schedule and things go on well. But in an unfortunate 20 to 30% of patients, it is possible the cells may start to come back. Sometimes it overtly comes back and starts showing up in the blood, that we call it as relapsed. Sometimes when you start giving therapy for it, and if it is not giving the same results what it has given the previous time with the same kind of therapy or a different set of medications, we start calling those leukemias as refractory. That is refractory to the first line of defense or the first line of therapy what we have given to the patient. So this is what we call it as refractory. In simple terms, I should say a leukemia which has come back. But today's with the development, I should say this percentage is kind of really coming down, but still good 20 to 30%, we still face this problem of relapsed and refractory.
Right. And is the incidence of refractory and relapsed leukemias higher in adults versus children?
Yes. Should I?
Yeah, go ahead. Go ahead.
Yeah, fine. Yes, to be more frank, if you just put it in a very gross perspective with acute lymphoblastic leukemia, it's common in children. But the other way around also, the percentage of people who are kind of getting completely cured, we call it as long-term remission. Sometimes we don't use the word cure, but still a long-term remission is quite high percentage in children. But being a very aggressive cancer, though it is not so common type of acute leukemia in adults, but when it comes up in adults, maybe due to reasons unknown many a times, but maybe sometimes due to the mutations which have occurred over our years of life, the box standard protocols which works beautifully in children sometimes may not be enough or may not be working to that extent in an adult. On a comparative basis, yes, in adults, I should say relatively the risk of relapse and refractoriness is a bit higher compared to a similar group of children, I should say.